Hi, I'm Dr. Louis Mazzarelli, the Director of Molecular Imaging at Lawrence Memorial and Westerly Hospitals. This is our prostate-specific membrane antigen case series. This is case series 4, biochemical recurrence. So what are our objectives? Define biochemical recurrence after radical prostatectomy and radiation therapy, including key PSA thresholds. Recognize the role of PSMA PET in localizing recurrence at low PSA levels. Apply a systematic approach to reading biochemical recurrent PET studies, focusing on the vesicourethral anastomosis, the lateral surgical margins, retrovesical and nodal regions. Differentiate true recurrence from benign or post-treatment changes utilizing CT and MRI correlation. Integrate imaging findings into management decisions, i.e., helping use PSMA PET to determine the need for salvage radiotherapy, systemic therapy, or multidisciplinary tumor board referral. Let's define biochemical recurrence. After radical prostatectomy, PSA should fall to an undetectable level of less than 0.1 nanogram per cc. BCR is defined as a PSA greater than or equal to 0.2 nanograms per cc on 2 consecutive measurements, and these are the consensus definitions of the AUI, EAU, and NCCN. After radiation therapy, PSA may remain measurable. Biochemical recurrence is defined as a PSA rise of greater than 2 nanograms per cc above the post-treatment nadir, as per the Phoenix definition. The clinical significance is that when we see a biochemical recurrence and we see a PSA rise, we know that there's residual or recurrent disease, and that may be local or metastatic. And that then triggers PSMA PET imaging to localize recurrence and guide salvage therapy. In BCR, this is our teaching point, PSA tells you that there is disease. PSMA PET helps you find it. So let's look at a case. This is a 64-year-old with a rising PSA, currently 0.28, stage 4 diffuse large B-cell lymphoma, a history of squamous cell carcinoma at the base of the tongue, Gleason grade group of 3, 4+3 prostatectomy, 12-14 biochemical recurrence of 0.01, most recent PSA 0.28, more recent increased PSA velocity in January of 2025 at 0.15, July of 2025 0.28. So let's look at this image. First of all, let's look at our normal biodistribution of disease on our spinning mitt. Normal biodistribution of disease within the lacrimal glands, including the salivary tissues. Normal biodistribution of disease within the liver and spleen, genitourinary tract, and bowel. We look down at the prostate region in a patient with a history of prostatectomy, and we see low-level uptake within the urinary bladder on this patient who underwent fluorophilostat PSMA PET. So notice the absence of uptake within the ureter and very low-level uptake within the urinary bladder. A couple things when we're looking at the PSMA PET is we're really looking at that vesicourethral anastomosis region and any area of uptake adjacent to or near, discrete from that urinary bladder. In this case, we can see a subtle, independent focus of neoplastic uptake or metabolic uptake along the margin of the bladder. Notice also that there's paired bilateral uptake within the axillary glands. And here we can see an arrow pointing to low-level uptake within the left axillary gland. And then also look again at that patient's focus of radiotracer uptake along the margin of the urinary bladder and low-level uptake within the bladder. Here again, we're seeing some additional low-level uptake, and this is slightly more superior within the retroperitoneum. So this is an interesting case. We see a patient with a low-level PSA 0.28, and we see multifocal areas of disease, including a single focus adjacent to the urinary bladder and other foci of potential disease within lymph nodes, both the axilla and perhaps the retroperitoneum. This is a cone down view of that solitary focus of uptake near the urinary bladder. And notice again that low level uptake within the urinary bladder that's allowing us to distinguish this focus of increased uptake from the urinary bladder on this fluorophilostat PET CT scan. And again, the absence of uptake within the ureter is very helpful as well. And also I'll note an absence of uptake within the urethra. So let's look more closely at this patient's fused imaging. Axial images demonstrates a focus of increased radiotracer uptake, correlating what we saw on the MIP views, and this is in fact at the seminal vesicle remnant. So it's an area of recurrence. Here it is on the axial fused, and also we see that same area of abnormal radiotracer uptake, abnormal metabolic uptake on the coronal fused image. So a subtle focus of uptake, but clearly in distribution or location typical for biochemical recurrence. What we see as well, however, are some additional low-level foci of uptake within the retroperitoneum, concordant with the the subtle foci of uptake we saw on the myth. And this is a patient, again, as you remember, who had not only a history of prostate cancer, but squamous cell carcinoma and diffuse B-cell lymphoma. So these are, in fact, stable lymph nodes concordant with the patient's history of lymphoma, not metastatic disease. And the clue here, again, being the low-level uptake with these lymph nodes and a low PSA. So both diseases present at the same time. And in this case, because of the small volume disease proven at the seminal vesical remnant, this patient went on to salvage radiotherapy and then with a election of pelvic lymph node coverage. And again, looking at two paired images of this patient's PSMA PET and concording that with the patient's FDG PET, showing the same distribution of radiotracer uptake within known, documented, unchanged low-level lymphoma, again, both on the PSMA PET and the FDG PET. So be wary of these other areas of radiotracer uptake that can be mimics of prostate disease. Always go back and correlate with your preceding imaging. So let's talk about biochemical recurrence after radical prostatectomy. It occurs in about 30 to 40% of patients within 10 years after definitive therapy. The median time to recurrence is 2 to 4 years after treatment. This may reflect local, nodal, or systemic disease. The imaging approach is to use PSMA PET-CT or PET-MRI if available as a standard of care for localizing recurrence. Detection rates increases with the PSA level. Less than 0.5 nanograms per cc, approximately 50% detection. Between 0.5 and 1 nanogram per cc, about 70%. And when the PSA is greater than 2 nanograms per cc, PSMA PET is able to detect disease greater than 90% of the time. So when we talk about patterns of local recurrence and biochemical recurrence in the prostatectomy site, the most common sites of disease are as follows. The vesicourethral anastomosis, 60% of the time. At the lateral surgical margin and remnant ducti deferentia, 25% of the time. And the retrovesical region, approximately 10 to 20% of the time. Note also that there may be other areas of local invasion, including the bladder, the urethra, and the rectum. And this is an example of the power and the importance of a sagittal fused image that demonstrates very, very low level uptake within the urinary bladder on this photophilistat PET-CT scan and clear abnormal uptake within the vesicourethral anastomosis. So clearly defined as being separate from the urinary bladder in a patient who has biochemical recurrence at the vesicourethral anastomosis. Always remember to look at your sagittal images when reading BCR cases and prostatectomy cases. Let's look at another case. This is a patient who has local progressive disease, status post-external beam radiotherapy. 75-year-old with a history of prostate carcinoma in 2011, Gleason grade group 4, within the right midgland at the apex. Patient underwent external beam radiotherapy, biochemical recurrence, 3.8 in 2018. So look at these patients' PET-CT scan. This is a fluciclovine PET that was performed in March of 2018, demonstrates the normal radiotracer distribution of fluciclovine, different from what we've been seeing with PSMA. Notice the marrow uptake, the uptake within the liver, and uptake within the pancreas. But there is a single focus of radiotracer uptake here within the prostate. Let's look at the axial fused images on this fluciclovine PET, and we see that this patient underwent external beam therapy. So we see the transponder beacons, and we clearly see low-level uptake within the normal prostate, but an intense focus of abnormal radiotracer uptake within the right prostate, concordant with the site of primary disease and compatible with a site of biochemical recurrence, but no other focus of disease. This patient went under continued surveillance and 3 years later had continued rise in PSA. That patient had declined therapy at the time and underwent additional PET-CT scan imaging. And that same focus that was less apparent on the fluciclovine is clearly very apparent on the axial fused images. Again, we see that same distribution of normal radiotracer uptake within the non-avid prostate, the treated prostate, but intense radiotracer uptake near the transponder beacons in an area of intense radiotracer uptake extending from the apex to the midgland. So when we talk about external beam radiotherapy, 15 to 30% of men treated with EBRT undergo or progress to disease. And disease may be often multifocal, but it may be focal at the original tumor site. So recurrence may exist not only within the gland itself, but with nodal or distant metastases as well in up to 1/3 of cases. Let's look at another case. This is a 69-year-old with a history of rectal carcinoma, prostate carcinoma, high-grade Gleason score 4+5, grade group 5, March of 2022, underwent prior cryoablation and had a rising PSA of 0.58. PET-CT scan in this case demonstrates normal biodistribution of radiotracer, uptake within the kidneys, and in this case, low level uptake within the urinary bladder, again, on a fluidofolostat PET-CT scan. So notice the absence of any uptake within the ureters and very low uptake within the urinary bladder, helping us discriminate not insignificant volume of disease, but an area that's immediately adjacent to and difficult to distinguish from the urinary bladder. So when we look at the axial fused image, we can see that there's very low uptake within the urinary bladder, but there's disease at the site of cryoablation, near the site of cryoablation, infiltrating and adjacent to the urinary bladder wall. But in this case, the absence of very low-level uptake within the ureters and low-level uptake within the urinary bladder made this very clear on the MIP scan. Another few images from the same patient, and this time looking at the sagittal images. And again, this was the patient's primary disease. We'll go back to that. Very high-grade disease, Gleason 4+5, grade group 5, again, in the central zone. So we know that that tumor location tends to be one that goes with aggressiveness. And on the sagittal images, we really see a beautiful pattern of disease here in terms of abnormal radiotracer uptake near and adjacent to the urinary bladder. And again, a low-level uptake within the urinary bladder, and a second focus of disease, which is more central and posterior within the urinary bladder. And here you can see that in the sagittal image from the fluidofolostat PET-CT scan. So there's two foci of uptake, and here on the coronal images. With respect to cryoablation achieves local control in most cases, but recurrence occurs in about 15 to 25% of patients depending on disease risk and treatment extent. Whole gland versus focal. Recurrence may appear within the ablation zone, at its margins, or in the untreated prostate region. So in this case, we have an untreated region in the central and more posterior bladder, but then we also had disease recurrence at the treated zone. And again, the presence of low-level uptake within the urinary bladder, very helpful here. Let's look at another case. This is a 67-year-old with Gleason grade group 2 prostate carcinoma at the left base, at the peripheral zone. The patient underwent nanoknife ablation, PSA at treatment 9. Currently, that uptake is 10. So let's begin by looking at the fluidofolostat PET-CT scan, MIP images demonstrating the normal radio distribution of disease. And in this case, we also see a focus of uptake clearly in a rib. But focusing on the prostate region, we see that there's an area of asymmetric uptake. And it's our job now to discriminate whether or not this represents disease or other. So looking at the patient's disease, the disease, again, based on the history, was at the left base in the peripheral zone. What we see is that there's an absence of uptake within the left base peripheral zone, left base transitional zone, and normal physiological uptake within the right peripheral zone. So this is a case of cryoablation where there's an outstanding treatment zone, but normal uptake within the adjacent prostate, which is mimicking disease on the coronal MIP. So it's very important to know where your disease was to understand where your disease is not. And again, correlating the additional focus of uptake within the solitary bone, we see that there's a clear anatomic rib fracture with bony callus and a well-defined fracture, and intense radiotracer uptake within the right rib. So in this case, this is a patient who has a minimally elevated PSA, but no evidence of disease recurrence at the nanoknife site, and similarly, an incidental bone finding of a rib fracture in the thorax, but no evidence of disease with the nodal basins or viscera. So a couple of other additional images showing you the absence of uptake within the left prostate, concordant with what was treated, and then an MRI for correlation. So this is pre-treatment. We see that there was disease, in fact, within the left peripheral zone, small volume disease. And post-therapy, we see that there's a typical appearance of a nanoknife ablation zone, which demonstrates T2 hypointense signal, retraction of the capsule, very normal morphology of the right peripheral zone and transitional zone. And again, concordant with that area of absent uptake, we see an absence of enhancement within the left peripheral zone and to some extent the left transitional zone, but normal uptake within the right prostate otherwise. So don't be fooled by a pattern of normal disease when there's clear treatment response at the post-treatment bed. So talking a little bit about recurrence after irreversible electroporation or nanoknife ablation. Nanoknife ablation uses high voltage electrical pulses to create permanent nanopores in cell membranes, inducing apoptosis without significant thermal injury. It preserves the extracellular matrix, nerves, and vessels, making it appealing for focal therapy near critical structures. PSMA PET can reveal viable tumor before a morphologic change. Reported recurrence rates subsequent to nanoknife is about 50 to 30%. Similar to what we've been seeing in the other focused therapies and in the situation of prior prostatectomy, variable with lesion size, technique, and follow-up duration. The role of PSMA PET demonstrates focal uptake within or adjacent to the ablation cavity, suggesting residual or recurrent disease, particularly useful when MRI findings are equivocal or distorted by local artifact. The teaching point is that PSMA PET can reveal viable tumor before a morphologic change, so closely examine the treatment margin. So in summary, our key takeaways: the definition of biochemical recurrence in the post-prostatectomy setting is a PSA greater than 0.2 nanograms per cc, or in the post-radiation setting, PSA greater than or equal to 2 nanograms per cc above nadir. The patterns of recurrence. Following prostatectomy, the occurrence may occur at the vesicourethral anastomosis most commonly, so always remember to review your sagittal images, at the surgical margins, including the seminal vesicle remnant, and pelvic nose, as well as the bones or viscera. EBRT, infield gland recurrence typically, but always be sure to review your pelvic nodes or bone. And in focal therapy cases, really look at that margin or that untreated region to assess for disease recurrence. PSMA PET detects microscopic recurrence across all settings, even at very low PSAs less than 0.5 nanograms per cc. PSMA PET differentiates viable tumor from post-treatment change. The clinical impact is that PSMA PET can help to guide salvage radiotherapy and allows for focal reablation or systemic intensification. Our teaching point: regardless of the prior therapy, PSMA PET turns a rising PSA into a roadmap for precise, personalized management. Many thanks for your attention to the PSMA case series. I hope the information provides a framework and foundation for your learning and interpretation of PSMA PET.